Hi, good morning, everyone. Welcome. And as Krupa mentioned, this is the first of 5. So we were hoping to do an in-person conference this year. Last year, we had a great Remember, Recover, Discover 2-day event here in Elk Grove, and it was fantastic. However, this year it's all online, which is great because now we have people from all over participating. And as Krupa mentioned, our Northwest Suburban CARA grant is a trio of organizations: the Elk Grove Village Cares, the Live for Lolly organization, and the Kenneth Young Center, all located here in the Northwest Suburban Chicago area, coming together under one SAMHSA grant to train, provide resources to first responders and other members of the various sectors in the community to provide Narcan, educate the community, and also to refer folks who are seeking treatment and recovery support services in the area. So this is our part of our team of our Northwest CARA Project team. This was last year at our great Remember, Recover, Discover event with the mayor of Elk Grove and other members of the team, members of Live for Lolly, the founder. So the Elk Grove Village Police Department is the lead agency. They're the fiscal agent. Kenneth Young Center and Live for Lolly, we are the 2 sub-awards doing the day-to-day work. We have 9 targeted police departments, including Elk Grove Police Department and other surrounding suburban police departments. And then our targeted communities are the Northwest Suburban suburbs of Chicago. And in terms of our staff who are working on the project, it's ever growing. But right now, we have Elk Grove Village Deputy Chief of Police, Mike Gaspari, and he is the project director for the CARA grant. Myself, the division director at Kenneth Young Center, I'm listed as the project coordinator for the federal grant. Daryl Pass is the manager of recovery here at Kenneth Young Center in our division, so he's the manager of the CARA grant within my division. And then Laura Fry, recently listed as the executive director for Live for Lolly. Is that your correct title, Laura? I'll let you announce that. Okay. And then Laura also has staff that we'll add probably in next week's webinar Wednesday. We'll be able to add more pictures. But for right now, this is your Northwest Suburban CARA team. I know that there are more folks, and we will add them next week so you can meet more folks if you come back. So why do we have a Northwest Suburban CARA? When we submitted our application in 2018, 6 of the 9 targeted towns had a combined total of 98 overdose reversals in the past 2 years. And that's a significant number in this small area in which we live in. Also, the collaborative approach of providing effective strategies to reduce crime rates, providing supportive services, and increasing community engagement and community partnership, it has proven to be effective in reversing overdose and also just supporting folks in their recovery process. And then we also have some Cook County statistics. You all will get a copy of this PowerPoint, so I won't roll through this because I don't want to cut into the conversation of why we need to talk about stigma, because that's really where you want to start the conversation, is around stigma and addressing stigma. But as you can see from this data, and even today as I was driving into the office, they were talking about on the news how alone in the city of Chicago, the opioid overdose rates are up by 50% from last year right now, and over 80% of the overdose cases involve fentanyl. So it's definitely something that is not going away. In COVID, there are disparities that are related, and it's not isolated just in one area. So there definitely is a need for us to continue this work. So our goal at the end of this project is for 100% of law enforcement in this area to carry and have access to naloxone. And when we started this, we did not have 100%. We're still working on it. That is definitely, we know that law enforcement, they are there first even before for fire and EMS, when we get a call, when calls are put out for someone in distress. And our other objectives are to conduct 20 community education events, because even before the 911 calls are responded to, their loved ones, friends, families, other folks in the community that are right there when it's happening. So if that person have Narcan on them, they can save a life. So our goal is to conduct community education events and to get naloxone into the hands of as many people as possible. We also want to train at least 2 village first responders in naloxone within a calendar year. Create and maintain community resource guides so that folks know after life is saved, or how where we can provide other resources, and such as smart recovery. We want to distribute at least 24,000 kits within the 3 years of the grant. Conduct prevention education. Certify at least 5 additional organizations through our training of trainers program, and then train 300 unduplicated individuals annually. It's always good to get a refresher, but we know that there are a lot of folks out there who have never been trained, and we want to make sure that every year we train at least 300 people. And we are already surpassing that goal. We're coming to the end of our first year, and we're already surpassing that, but we know that there are more folks out there that need it. So this is Mike demonstrating how it could be part of your AED kit, wherever, if you have an AED, you have, a fire extinguisher, you can add that to it. So what we want to do is we want to make naloxone available. We want to train folks in the Good Samaritan law within our state, if you have it in your state, those who are on the webinar who are not from Illinois. We want to train in safety around illicit and illicit drug use. We want to talk about harm reduction, teach folks about harm reduction. Laura's going to talk about that. And then we also want to establish process and protocols for referrals to treatment and recovery. And then we work with the Communities for Positive Youth Development Coalition, the CPYD Coalition, but other coalitions in the area, talking to them and training them and getting training of trainers in the area. And the other communities around us is the other part of our CARA grant that we're doing. So as part of the grant, we're required to use FDA-approved overdose reversal medication. So for us, the most cost-effective, of course, is the vial, which is you use a syringe, and that we help to distribute to as many folks in the community. And then the nasal Narcan, we are distributing to the police departments, first responders. So that's what we have on hand, and that's what we're able to provide. And if you are interested, if you're a community organization, police department, etc., you can contact me directly. You can contact Laura. We'll also have her information. You can contact Daryl. But if I just wanted to put my information up here. But you can contact me via email or phone call. We're funded through SAMHSA. These resources are available free because it's through our grant. As long as you are in our service area, the Northwest Suburban Cook County area that we just listed, then it's free to you because of our grant. But as we said before, with Webinar Wednesday, we really want to start off by talking about stigma, because one of the greatest hindrance to recovery and getting support is stigma. And so having said that, I want to turn it over to my good friend Laura, my sister. And Laura's going to talk about stigma. Thank you, everyone.
Thank you so much. Now I have to figure out how to share my screen. Bear with me. Okay, I think I can do this. Well, I tell you, before this COVID situation hit, I was not the brightest technology bulb, but I am learning. My name is Laura Fry. I am with Live for Lally. I am currently the Chief Programs Officer, but I was recently appointed to the Executive Director role, which I will be taking over next week. Thank you so much for being here. Stigma and language are two of my favorite topics, and I have to tell you, when I was going through my son's heroin use disorder 8 years ago, I was not the person I am now. I am ashamed of the language that I used, but I became educated, and when we know better, we do better, right? So some of the goals that we are hoping to achieve during this presentation, as humans, we all have some preconceived notions, right? Or biases, prejudices, or judgments. Sometimes they are benign, like my meatballs are the best, so I won't eat them anywhere else. But sometimes they can be hurtful or outright damaging. My hope is that after this training, you will start looking inside at your preconceived ideas about substance use disorder and mental health disorders, and look beyond the label. Make eye contact and see that the person has strengths, has talents, as well as challenges. So what is stigma? Stigma is very complex. Stigma can be both internal or self-stigma and external. Stigma that elicits a negative feeling can result in people feeling undesirable or shameful, and it results in negative attitudes and responses from society as a whole. People living with substance use disorder and or mental health disorders already experience stigma. Add any of the rest of these factors, and that stigma-driven prejudice and discrimination rises exponentially. All of these things can come into play with stigma and many more. A person's socioeconomic level, their gender, invisible or visible disabilities. It all stacks into multi-layers of stigma. Stigma creates prejudice and discrimination in receiving medical care, housing and employment opportunities. Just ask someone being released from prison how easy it is to find a job. Lack of healthy support network, social isolation, and all of these things can lead to loss of hope, depression, poverty, physical illness, and potentially suicidal ideation. So I would love to see what do our attendees think some of the effects of stigma are. Just randomly type your answers into the chat box. I'd love to see what your ideas are. So some of the effects of stigma, like I said, housing, employment, medical care. I come from an ER nursing background, and there were a lot of things I saw that were preconceived notions that people had about certain illnesses. And when you are someone who is challenged with substance use disorder or mental health issues, the negativity that you see outside starts to come inside, and you start to self-stigmatize, believing the negative stereotypes that are put on us by society, by media, sometimes by our own family members. And then what happens is we tend to avoid seeking help because we already know how people feel about us. So we isolate, and these issues grow. Stigma erodes confidence, self-esteem. It leads people to avoid socializing. It damages and destroys family relationships. And it stops people from seeking treatment because they fear that they won't be treated with respect, that they won't be treated with dignity. And stigma is powerful and all-pervasive. And if a person does not have the ability to reach out to obtain treatment resources or to make that connection with healthy people, those destructive patterns get worse and continue. There is a twofold impact of stigma. One is the public stigma, how the public sees us. Stereotyping. People with substance use disorder are dangerous. They're weak. They're incompetent. Prejudice is when you agree with those stereotypes, and that can result in feelings of anger or fear of certain people. And then that leads to discrimination, a behavior response to our prejudicial thoughts and feelings. And then when all that happens, we start self-stigmatizing. We start believing that negativity. We start believing that we're weak, that we're incompetent. And we also start believing in the prejudices. We agree with that. That leads to low self-esteem and efficacy. And then that leads to self-discrimination, our behavior response to prejudice. This is a graphic that ties together all of the harmful effects of stigma. You might not see all of these at the same time, but we all have experienced this, those of us who have lived with the challenges of mental health disorders and substance use disorder. This was a study that was done by the Recovery Research Institute, where people were referred to as a substance abuser and the other person as having a substance use disorder. And what they found is that representing people as substance abusers was a negative. They were more likely to be looked at as a threat. When you call someone an abuser, that indicates that they need to be punished. When you call someone an abuser, it indicates there is blame for their disorder. And it also indicates that if they were just able to control, if they were just able to stop. But when you refer to someone as a person first, having a substance use disorder, it changes how the public views that. Substance use disorder is probably one of the most stigmatized conditions in the U.S. Oftentimes, SUD is co-occurring with mental health disorders, also something that is very stigmatized. When you have both, it's very, very difficult to break out of that for fear of being judged, for fear of being discriminated against, and people just don't get the help that they need. So I'd like everybody to look inside and ask yourself these questions. How are you representing your prevention and recovery messages? Are you using person-first language? Are you using technical language instead of inconsistent definitions or sayings that don't represent the true nature of the disorder? Are you being sensational or fear-based? I am remembering back when I was younger, the egg frying in the frying pan. This is your brain on drugs. That's sensationalism. That's using fear-based. Are you unintentionally perpetrating societal and moral panic about these disorders? So I wanted to offer some tips to those professionals that are attending this presentation today. Ways and tips of avoiding stigmatizing language. I'd love to see everybody perform a language audit. I did that here internally, in-house, and changed all of the potentially stigmatizing language. Get rid of words like addict and replace it with a person with a. Look for places that you're using the word abuse. Abuse indicates someone that needs to be punished. And these are not people that need to be punished. These are sick people that need help getting well. Look at your mission statements and your vision statements. Look at your policies, even your employee handbooks. Are you using stigmatizing language of any kind? And if so, I really encourage you to take a deep dive and look at your own policies, internal and external. When you speak to the press, when you speak to a newspaper reporter, are you using stigmatizing language? Please take a look at that and see where you can make changes. And I would love to see everybody, all professionals, really reflect on the types of information you are disseminating to your partners, your colleagues, your staff, the community that you serve, and your participants. Is anything in your message pointing to a victim or a bad guy or weakness? Is there anything in your message that can't be sourced? Is your message data-driven? Are you conveying this information accurately? Or are you unintentionally editorializing or adding commentary that would bias the message? Again, take a deep dive. Take a look at how you are representing people with substance use disorder and people with mental health disorders. Every time, I know we do this here, every time you develop a message or a social media graphic or an op-ed, ask yourself, who's your intended audience? And what language can I use that will reduce stigma when I communicate with these group of people? Does the language that you are using foster self-worth and encourages self-efficacy? Are you holding your allies accountable for their negative attitudes and language? You can help change that perspective by acknowledging it. And most important, are you maximizing connection and worth? And that these people are community members. Shame and stigma can be veiled, and you have to really take a look at the message that you are putting out there. It very well might not be your intention to ever shame someone. I know it's never mine. But we have to continually audit ourselves and the message that we are giving. When developing new materials, seek out your stakeholders. If you are a treatment facility, seek out your current participants, the current people in your program. How do you feel with this language? What do you want to see change? Now, I have to say, I am, and I've been a part of the 12-step community. What happens in a meeting is dependent on the people that are there. If people want to identify as an addict, as an alcoholic, I don't feel it's my place to tell them that they can't do that, but I don't have to use that language. So when I go to a meeting, I am a person in long-term recovery. And that's how I identify. So you kind of have to be careful. You can't shame someone for how they identify, but you don't have to reinforce it. You can just use your own language. Always train your staff on how to not stigmatize. Make a point of giving information about the negative health, physical and mental health, and community outcomes that are related to the perpetuating of stigma. And keep an eye out for those inadvertent ways that all of us, and if you are a human being, I would argue this with anyone, there is something. There is something inside, or something that, some preconceived notion that you have about something. So look inside and have your staff do the same thing. Engage your staff in exercises that will stretch their preconceived notions and how they discuss individuals or cases. How can you explore alternative language? And how do you get people to adopt that language? It really does take practice. So we have some words that are commonly used and words we would like to see them replaced with. I do not like the A word. I think that it has negative connotations. So the simple way to remind yourself to do this is to always start with the word person. Person with alcohol use disorder. Person with heroin use disorder. Instead of saying drug abuse, try to get rid of the word abuse and any of its forms altogether. Drug misuse or harmful use or dangerous use or non-healthy use. Clean and dirty. Two of my favorite terms. Personally, clean to me is when I get out of the shower, and dirty is after I've been working in the garden. Those are such negative terms to someone who is fighting substance use disorder. You're either actively using or you're abstinent or not actively using. Drug screening is either negative or positive for substance use. It's not a clean drug screen or a dirty drug screen. That indicates that the person themselves is clean or dirty. We can use negative and positive. Sounds better. Person in recovery. This is Recovery Month. That is a term that is preferred. And opioid replacement therapy. We try to stay away from that. We talk about medications for addiction treatment or substance use treatment. Replacement makes it sound like you're taking one problem substance and just replacing it for another. And we know that opioid replacement therapy or medications for opioid use disorder are very appropriate for opioid use disorder, and there is a lot of data saying that it works. So we want to try to remove that replacing one drug for another, which I hear from people with SUD all the time. And that's dangerous thinking. Again, going back to my childhood, sometimes I think it's harder to survive and get over people's words than it is if someone were to punch you. Words tend to continue to roam around your brain and come out at not the best times. So let's try to be really careful with our words. Words are weapons. Words hurt people. And when those words are used to shore up stigma and shame, it just snowballs and creates a bigger problem. Some of these words, I bet there are people in this presentation that still use. What I would like to see, I put the word retard here, which is a word that elicits a lot of anger if someone uses it. I'd like the rest of these words to get like that too. If you were out in public and you called someone a retard, the negativity that you would see would be immediate. Not so much if we go out and we say that someone's an addict. I kind of would like to see that same response. Person first language emphasizes the person. We as humans are many things. We are not just an addict. We are not just a female. We are not just an executive director. We are many, many things. So when we refer to someone as an addict or as a diabetic or as an autistic, that is reducing that person to that one thing. So I challenge you to use people first language in every scenario, not just with substance use disorder or mental health disorder, but in all areas. A person with diabetes, you would never refer to a person with cancer as a cancer, right? Always person first. And yeah, how about we just refer to them as humans? Humans, that's all encompassing, the whole person. Someone's substance use disorder is but a part of them. There's so much more to that. And once we can get the individual to see themselves like that they are so much more than this label that society has given them, we're going to see healing. But if they don't believe that about themselves because what they see on the outside, how do we overcome that? So these are some things that help sustain stigma: maintaining a distance, not going to visit a friend anymore because you know that her son is struggling with drugs. Expressing your disapproval. Well, why can't they just stop? Feeling superior. I have seen this in my own smart recovery meetings. People with alcohol use disorder feeling that their SUD is better than people with heroin use disorder. People with heroin use disorder feeling that way about people with methamphetamine disorder. It's the same brain process. Doesn't matter if it's alcohol, methamphetamine, self-harm, eating disorders. It's that same brain process. Feeling like you can't engage with certain people because of fear, because you need to feel safe. Trying to control the situation. You can't control it. For those of you that are 12-step people, remember the prayer that we always use at the end of meetings, right? The serenity prayer. Change the things we can and recognize the things that we can't. Do not say things that are going to hurt people. A lot of times we speak before we think. We all do that. We're humans. And that's okay. But apologize if you've hurt someone. So ask yourself, do you stigmatize others? What are your personal beliefs? And a lot of us might have personal experience, and it's really hard if we have grown up in a family with parents that had substance use disorder, or we went through child endangerment or child abuse because of, or neglect, whatever it is. If we have a personal connection to someone with substance use disorder, we might have these preconceived ideas. So check your personal beliefs about why people become addicted to substances. Do you think certain types of substances are better than others? Are some accepted and others not? Look at alcohol use disorder. We still, every year, lose more people to alcohol use disorder than any other substance. Why do we not talk about that so much? Because it's accepted? It's not only accepted, it's expected. Do you believe some people are beyond help? Oh, he's been using for 35 years. Nothing's ever gone changed there. That's stigmatizing. Do you think that some treatment approaches are better than others? Do you have the feeling of what worked for you is what should work for others? Do you have a blanket thought that 30 days in is the only way? That medication-assisted treatment is the only way? Anytime you start thinking that you have all the answers, I challenge you to think again. Do you think that recovery has to look a certain way? Do you think that recovery can only look like 90 and 90 after you get out of treatment? Or do you envelop the idea of meeting people where they're at, meeting people's needs as individuals? Stigma is both conscious and unconscious. I see that in myself all the time. So this is one of my question breaks. Krupa, have there been any questions?
Yes, there has been one question from Suzanne. So I hope I'm getting the question correctly, but Suzanne earlier was talking about the terminologies licit versus illicit drugs, and Suzanne asked that they use those words in their documented cases noted at the place of their work. How do we feel about those words? So I wanted to ask you, Laura, what do you feel about the terminology licit versus illicit drugs? Do you feel like it's problematic, shaming, or stigmatizing?
All of the above, yeah. I do feel that it is, because it indicates that one is worse than another. And we all know people who have misused medications that were prescribed to them that are dead. So when you use words like licit and illicit, I understand the reason for that, but one indicates criminal behavior and the other one doesn't, and they are equally as dangerous to quality of life. Does that answer a little bit?
Yeah, I haven't heard back from Suzanne, but let us know if you'd like to follow up. If anybody else has other questions, please feel free to type them in. Actually, Lisa is asking, are there alternatives to using licit versus illicit drugs in, I'm guessing, formal settings, like doing case notes?
Not being a professional social worker or a CADC, I'm not sure how that documentation works. I know that in the medical field, that is how we coded things, and how you code things is how you get reimbursed. I don't know if that's the same thing in treatment facilities or with therapy, but I think that would depend on if it is tied into your coding and reimbursement, and then there really isn't a whole lot to do. We can appeal and advocate for insurance companies to change their language, but that's a whole big deal. But you don't have to use it in your language when you're talking to your clients or participants or your colleagues.
Yes, absolutely. That is where Suzanne was going in terms of wanting to advocate for changes. Yeah, and so folks, I encourage you to share any other questions or comments that you have. I know that Peter shared earlier that, you know, quote unquote, you cannot hang your biases on a hook outside your office. Clients can always read your heart and see any bitterness or judgment.
Oh yes, they can see right into your soul, especially when you're trying to avoid eye contact or getting close or just a touch. Not that we're able to touch in these days, but
Yeah, and Shireen brought up a great point about code switching. And I think that is in reference to how sometimes in formal documents, we may have to use certain words, but when we are speaking with our colleagues or our clients, there is another way of speaking, another way of communication that we take on to be more humanizing.
I know that when I'm working, I'm a recovery coach, so when I'm working with an individual or leading a SMART meeting and someone self-identifies as an addict or an alcoholic, I don't correct them, but especially when I'm working one-on-one, I always ask, okay, I can accept that you're struggling with a substance, but what else are you? And they always look at me like, well, what do you mean? And I'm like, well, what else are you? What are your hobbies? Are you a son? Are you a mother? Are you a friend? Are you, and I engage them in making a list of all that they are. So I don't say, oh, don't refer to yourself like that. That's a negative word, because that wouldn't be meeting them where they're at, right? But I try to reach them and help them look beyond that label just for themselves, so that they can see themselves as the whole person and not the person with this disorder.
Yeah, absolutely. So we have a question from James, and James is asking, when working with law enforcement, how do you recommend educating about drug addiction issues to decrease stigma and elicit greater empathy towards people struggling with addiction?
Well, especially in this day and age, right? We all are trying to encourage our law enforcement to be kinder and gentler. I wish I had the pat answer. Do 1, 2, and 3, and it'll all be fixed, but I don't. I think that you can start with your local police department. I've done this with my local police department. We also offer this language and stigma training to anybody who wants it. Police departments as well, and we have had several police departments that have asked us to come in and do language and stigma training. And, you know, just anytime you encounter law enforcement, be sure that you use the right language instead of correcting them. I have found that when we counteract, so for example, if I were to get a phone call from a police officer, which I do frequently, asking me to respond to an ER call of an overdose. Yeah, we got an addict that overdosed on heroin. Can you go to the ER? Oh, so you have a person who had a heroin overdose? Is this person male or female? You know, and then I try, instead of correcting, saying, you know, I'd really like you to not use that language, I respond with the right language, or the language that we want people to start using. And I think the more that we do that, it's going to be like a seed, like a subliminal seed that gets planted. Every time someone uses the language that we are trying to get away from, we repeat the language that we'd like to see people use.
Yeah, and Shireen followed up to share that she recommends folks visit pariusa.org. I believe this is, Shireen, would you like to share what PARI does? I can.
Please, that would be great.
PARI stands for the Police Assisted Addiction and Recovery Initiative. I think that they have a lot of resources on how to work with law enforcement to change the culture of how we treat folks who are using substances.
Yes, and so it started with just one police department, and a lot of the work that they do, we attended Daryl Pass from our team, and I attended their conference last year. A lot of great work out on the East Coast in terms of working with dispelling stigma, getting naloxone into the hands of as many people as possible. A lot of the talk that you hear about with defunding the police in terms of getting dollars into social service type of programs and recovery type programs within police departments is some of the work that folks are doing through PARI type initiatives. A lot of innovative work that they're doing out there. So if you look at that website, you'll see what some police departments are doing in terms of working with communities in a collaborative way that is non-stigmatizing, and then also that is, recovery person first oriented type of work. And they're very open to providing insight and technical assistance to anyone who is looking to work with the local police departments in that manner. So I would recommend that people reach out to that organization to see what they can do, because like Laura said, it is not easy. And I know that there are a lot of systemic issues and there's a lot of foundational issues that need to happen. That is not simple. And so this is just one tiny way. But I will say that their big thing is that addiction is not a crime. And so that's the posture I would say that they take. So yeah, just look at their website and look at some of the strategies that they're implementing.
Thank you so much, Shireen. Great organization, PARI. I was doing a naloxone training about 3 years ago for a local police department, local to where I live. And I had one of the police officers I was training refer to my Narcan as anti-Darwinism. And that's about the worst thing I've ever heard. And thankfully, this was a police department that then had me back to talk about language and stigma. And all I met this officer with was kindness and compassion. And I said, I'm really sorry you feel that way. And if you ever need any help, I'm here to help you. instead of getting into a negative altercation. I was not going to buy into his stereotyping and stigmatizing language. It might be the Buddhist in me, but I always meet negativity, or I try to always meet negativity with kindness and compassion. And like my mother always told me, if I can't say anything nice, shut your trap. So that's where I come from. Krupa, any more questions?
Yes.
I know that it's really hard to sit through 2 hours of constant slides and listening to someone like me. So we are going to take a little break unless there is more questions.
Yeah, we do have 2 questions, and I'll go in order. Mike said, quote unquote, "I don't like the word crazy, but so many people use it in different situations as slang, and correcting people comes across as superior. Don't you think?"
Exactly, and guilty. And I am someone who has been treated for major depressive disorder since I was 15. So I am someone with mental health disorders. And how often do we do that? You know, you'll get a phone call from a friend. How you doing? Oh my God, I'm going crazy. I do it all the time, and I have to check myself. So that's what I mean about taking a deep dive and looking inside. I do it myself. And again, what I try to do is mirror that with language that I would prefer to be used. So when I say that, I would prefer someone to say to me, "Oh, so you have a lot on your plate right now and you're a little overwhelmed?" And then that's my, "Oh yeah, check myself. I said crazy again, didn't I?" And I know what you mean about sounding superior. So I always try to make it look like I'm not correcting people, but just mirroring the right language. And I don't know, Mike, do you have some suggestions on how I could stop saying that I'm running around like crazy? Or because I do it all the time.
Yeah, I would like to share. I also struggle with mental health, and when I was young, the word crazy felt very empowering because it felt like it was the only word that could describe all the energy, chaotic energy within me. And one thing that I'm a fan of is that language always changes, and we can always create new words to describe who we are. And sometimes I'm like, why don't I replace crazy with "I'm going through a supernova right now"? You know what I mean? I'm going through a supernova. Everything is exploding, expanding, creating. But I thought I'd add that.
I love that. I'm going to adopt. I'm going supernova. Love it.
Yes, because oftentimes after I have moments where I'm going through a supernova, I also reach some moment of enlightenment. Not to
Yep.
go after the Buddha thing, but I got a lot of respect for Buddha as a South Asian. I admire his work and his legacy. But actually, I digress. Mike, we would love to hear from you if you'd like to follow up on alternatives to using the word crazy. I also want to share that James asked a great question. He asked, "Laura, do you usually talk about your personal experience with addiction when training? I think police officers benefit from knowing that treatment works and can help dispel those Darwinian sentiments."
Yes, absolutely. And for those of you that know Live for Lolly, you might know that my son works for the organization as well. And when the two of us are doing training, we are always talking about our own substance use disorder. I had a cocaine-induced heart attack when I was 20. I have been challenged by mental health issues as long as I can remember. I am always very vulnerable and very open talking about my own issues, as is my son, because he was an IV heroin user, and he does a lot of training with police departments. And for him to stand up there in his suit and tie, you know, with his crisp haircut and just looking like $1,000,000 and say, yeah, I used to shoot dope. I was homeless for 8 months. It gives people a contrasting view of what their preconceived notion is. So yes, absolutely. Anyone who's heard me do any kind of training, I always talk about my own stuff. I think it brings humanity. I am not above any of the people that we work with. I've struggled with the same things.
Yes. There's a follow-up comment from Elizabeth who shared that also to acknowledge that some first responders adopt such beliefs as a defense against seeing pain and suffering repeatedly and feeling hopeless to make a lasting impact.
Absolutely. And I know that firsthand. I spent 15 years working in an emergency room, working very closely with all of our EMS departments, and it does turn into a coping mechanism when you repeatedly go back to the same house for the same person overdosing for the 4th time in 1 week. Absolutely. I can feel that. It is part of the many reasons why I am no longer working in an emergency department and I'm doing nonprofit work instead. It got to be a bit much.
Yeah, most definitely. I would also want to answer a question I think might be urgent, is that somebody asked they haven't heard anything about CEUs. I would like to share that all registered participants should have received an email that at the bottom of it says information about CEUs. I will share the link in the chat if you have not filled out that document to receive CEUs. But if you go to your email and search CEUs, the email that has the link should pop up nonetheless. I also wanted to affirm that Anna was sharing that instead of using crazy as a blanket statement, which is where lazy language stigmatizes, we can break it down to more specific feelings.
Yeah, I like that, by saying overwhelmed or too much on my plate, or yeah, absolutely. Thank you. I am going to make a pledge to everybody here that I am going to consciously try to stop using that word when describing my chaotic and overwhelming life. Choice. Choice implies that someone woke up one day and said, you know what? I think I'm just going to become addicted to heroin. I think I'm just going to start using meth and let it ravage my mind and body. I've worked with a lot of people that have substance use disorder, and none of them made this choice. Maybe the first time or the second time, but no one in first grade, when asked, what do you want to be when you grow up, said, I'm going to become addicted to heroin. I'm going to become an addict. I'm going to become an alcoholic. It's not anyone's choice. Initially, yes, people might agree to trying a substance, but the brain changes. The reward center changes. Our brain stops creating substances that it needs to survive. Our brain's dopamine, serotonin, melatonin gets all messed up and it stops producing it. And that's what leads people. You might have heard someone say that substance use disorder hijacks the brain. It really does. People will continue to seek out, will continue to use, despite the terrible consequences that come from it. And that's the only thing I can compare it to is a complete hijacking. anyone out there who has substance use disorder knows that there's fentanyl in everything. But the substance is still used. So if that doesn't elicit some feelings of compassion and empathy for the lengths that this disease goes and forces you to go, this is no choice. I know that when I think of the word abuse, I think of someone who beats their spouse. That's an abuser. Someone who hits their dog. God forbid, don't ever hit your dog. That's an abuser. It is a term that implicates only negative. I really can't think of a scenario where abuse or an abuser would be a positive thing. And when you refer to someone as an abuser, what does that indicate? What does society do to people who abuse their spouses, to people who abuse dogs, to people who abuse children? They receive punishment. So when we take people who have a disease, have substance use disorder, when we take that and we lump them into the same category as abusers, that doesn't work. That's taking someone who's violent and abuses people and or things, and takes someone with a disease and makes them the same. It is not the same. When you refer to someone as an abuser or as abusing, that becomes a social threat, and people back off. People don't want to be involved with that. And it creates a lot of blame. I have never met anyone with substance use disorder that doesn't have so much self-blame, so much self-hatred, so much shame. There is nothing we could do that would be greater than what they haven't already felt about themselves. So why don't we lift them up? Why don't we reach a hand out and try to lift them out of that dark place instead of perpetuating the stigma and judgment? People with substance use disorder are seen as dangerous and unpredictable. And this is where the line gets a little fine, because I have encountered people on using certain substances that are unpredictable. When I spent a good portion of my life living inside of a vodka bottle, I was very unpredictable. But that does not equate treating them with unkindness or treating them with hatred. The stereotypes of dangerous people also influences public policy, medical care, healthcare coverage, mental health coverage. Believing that a person's substance misuse is a result of their own behavior, their own morals, their own weak-willed. Yes, that's a good word, weak-willed. All that stereotype of dangerousness and unpredictability does is perpetuate that these are bad people. These are bad people that need to be punished. These are not bad people. These are unwell people or sick people that need people like us to help them. Alcoholic, junkie, tweaker, and dope fiend. I have to share, because I always share personal stories, my son likes to refer to himself as a righteous dope fiend. I cringe, but I can't tell him how to refer to himself. But we don't have to share language like that. It's different when someone self-identifies than when you say you are a. It just puts a different spin on it. So always remember person first language in any health condition, in any disorder. A person with heroin use disorder, a person with diabetes, a person with cancer, a person who engages in self-harm, a person who has suicidal ideation, a person who died by suicide. That's another word that I aim to get rid of. Committing suicide. The word commit gives all kinds of negative connotation. People die by suicide. People take their lives. People. Person first. Clean and dirty. I talked about that before, but it is really two words that I strongly dislike. I also don't use the word hate, but I strongly dislike them. When you refer to someone as being dirty, I mean, what images do you come up with in your mind when you think of a dirty person? I find this one to probably be the easiest one that we can change in our lexicon. It's a positive drug screen or a negative drug screen. I mean, those are the medical terms that we use, so why can't we expand that to everyone else who works with people that have SUD? Positive or negative? Currently using or abstinent? Currently using, not currently using, but I think negative and positive is a pretty easy way to get away from that clean and dirty. And this is also a term that we hear very, very often, rock bottom. There really is no concrete definition for rock bottom. What could have been considered my rock bottom was having a heart attack when I was 20. That scared me, and I stopped using stimulants. In my mind, the true rock bottom is death. So how about we raise people's bottom? How about we encourage them to not wait until they have nothing? The rock bottom theory indicates that until someone hits that, treatment will not be effective, and that is just not true. So let's try to think of another way to talk about this instead of saying to a family that you're working with, oh, they haven't hit rock bottom yet. When you say something like that to a mother who has a child that is struggling with substance use disorder, they haven't hit rock bottom yet. Nothing will work until they hit rock bottom. What on earth does that even mean? And as someone who watches a loved one suffer through this disease, every single day is a rock bottom. Every single day that they have that vacant look in their eyes, or they're dope sick, every single day can be a rock bottom. So let's assist the substance user to not wait for that rock bottom, because oftentimes it's death. And we are currently losing 192 people a day to overdose. When I started with Lifrolali 8 years ago, it was 99 a day. Folks, we're going the wrong direction, and we all need to work to make this better. Another term that I cringe when I hear this on the news: a baby was born addicted. And if you read the definition in the DSM-5 of what substance use disorder is, when you say that a baby was born addicted, you just sound ignorant. Because a baby cannot be born addicted because they don't have the wherewithal to continue with a behavior despite negative consequences. And that is the definition. They can be born in withdrawal syndrome, but babies are not born addicted. It's not possible. So instead, use baby first, baby with neonatal opioid withdrawal syndrome, neonatal abstinence syndrome, a newborn exposed. But babies cannot be addicted. And this is one term that I have definitely corrected people. I've even written letters. I heard someone being interviewed on Good Morning America once a few months ago, and I immediately sent off a message that they were portraying this incorrectly, and I asked them to change their language. With media, we can do that. We can definitely correct them. No worries about feeling superior, because secret, oftentimes we are, where the media is concerned. So babies cannot be born addicted. And this is one of my favorite lines. Where do labels belong? Labels belong on jars, not people. So if you don't remember anything else from today, try to remember labels are for jars, so that when you catch yourself using a label to describe a human being, you can have the picture of this jar in your head, or think of pickles or something like that. Labels belong on jars. Lose the label. Any questions so far on that part? I'm going to go into a call for action.
Yes, there's actually been some really great comments. I think that a lot of folks have been talking about what rock bottom means to them, and I think that there is some diversity of opinions. Let's see. I know that Mike asked that, we'll go in order. Mike asked that some people feel like the word disorder is stigmatizing. So usually Mike says someone struggling with issues of substance use. Is this okay or not okay?
I love that. I love that. I tend to use misuse instead of disorder. But I don't know what do y'all think? Is the word misuse stigmatizing? Someone who struggles with substance use. I love that. But yeah, Mike, I totally agree with you. Disorder can, in and of itself, have a negative and stigmatizing connotation. So I'm writing that down, as I think I'm gonna start using a person who struggles with substances, a person who misuses substances.
Yes. Yes. And I had also added that in the mental health community, there has been discussions on whether or not what we call as disorders should be defined as disorders. And I just wanted to follow up in the chat section that there has been a study done, which was talked about on Forbes about whether mental disorders like anxiety, depression, or PTSD are even if they are disorders at all. So I encourage people to look at that, even though mental health and substance use is not always the same, but does definitely intersect in many of the people that we serve. I also wanted to go back that I think I wanted Laura, I'll just read to you some of the comments that people had about rock bottom to see what your thoughts are, because I want to make sure that we're being critical with our understanding of this term, and whether or not it does help us to use this term when we are speaking with our clients who are giving up their trust for us to support them. So let's see. Janine says that, quote unquote, I always say rock bottom is when you stop digging.
When you stop digging, yeah, I like that.
Yes.
When I'm providing recovery coach services, I ask the individual, what would your rock bottom be? I ask them to identify what they feel their rock bottom would be. And then it's always like, okay, so let's not dig down to that level. Let's start right here today.
Yes. And I also think that it's important when we're talking about rock bottom is to consider the context of the person's life, because if somebody is in a situation where they cannot access medicated assisted therapy or it's too far away, I know that recently in the recovery community, Dylan from Ohio, I think you posted about it, Laura, passed away, and this individual was a director of harm reduction services at Ohio Harm Reduction Organization. I never knew Dylan, but when I read about her life, it said that Dylan had to wake up every day at 6 a.m., I think, to get to a treatment facility to get methadone, and it was an hour bus ride there, an hour bus ride back, and the article said that under these circumstances, it is hard for people to keep up with getting access to medication that they need to survive. And so sometimes I feel as though we might be stigmatizing other people by saying, oh, they've hit rock bottom. Well, we should also be asking, are there resources for them to survive? Are we providing housing for people who are struggling with substance use? Do sober living facilities make sense for all people? Are we going to kick people out because they started using substances? Do we have healthcare? If somebody's undocumented, in my experience with working with Smart Recovery, it has been very heartbreaking thinking about some of the folks that I've worked with who are undocumented, who are barred from having any access to Medicaid. So rock bottom, sure, they can reach a point where things are very, very bad. However, there's not much help. So I think we also have to think about, are there resources available for this person to meet their basic needs? I apologize, you just heard my email go off. I'm talking a lot, so I want to go back to another comment. Elizabeth shared that I can't agree more with this rock bottom conversation. When someone hits the lows and returns to use, the idea is that things need to get worse before they get it. Thank you for bringing this up. Let's see. Joanna says, framing rock bottom in the context of death to folks is absolutely destigmatizing. Yeah, so I don't think that there are any other questions.
I really appreciate all that feedback, because I always feel that I am learning and evolving, and I might be the trainer, but I really learn every single time that I do any training from the participants who are giving me feedback. So I really, really appreciate all of your input, and I always take it to heart. That's why when we get to the CEU slide, I'm also asking everybody to fill out a presentation feedback form. I take them to heart. I change how I present depending on feedback that I get. So I would really appreciate it if everybody would do that when this is over as well. And please keep giving input and asking questions. This is awesome. So I never do anything without a call to action, especially when it comes to people with mental health or substance use issues. We right here are the change. Let's be the change we want to see. Because we can do it, and it's sometimes just as simple as changing our own language when we're out speaking to family and loved ones, and at the grocery store, just always putting forth the language that we want to hear our patients and clients and participants referred to as. So what are some things we can do right now? Stop labeling. That's the first thing you can do today. Just stop using label and put person right in the front of your head. Curiosity, you know, encourage people to ask someone, how did you get here? What was your experience like? Always using not only person first, but I language. I am worried about you. I would like to help you. How can I help you? Asking open-ended questions. Most of the people with substance use issues that I've met or work with, and we do street outreach in 4 counties. When I make eye contact and I say, can you tell me about your substance use? Can you tell me about your day-to-day life? The idea that someone that they put as higher than them is looking them in the eye and say, tell me about your day today. Tell me about how you're surviving. Tell me about your needs. Tell me about your wants. I've seen it time and time again. You see a switch in their eyes like, wow. And I've had people say to me, you don't really give a shit. And I'm like, yeah, I really do. Please, I want to hear from you. And always making eye contact. So that's cultivate curiosity. Develop connection. Share stories. That's why I always talk about my own substance misuse, my own mental health struggles. Not ever to say, I know how you feel, because we can get into that tricky place as well. Oh yeah, my son used heroin, so I know how you must be feeling. No, we really don't. We can share how we felt using your I language, but it can also be stigmatizing if we say to another person, I know how you feel. Because even 2 people who have been through the exact same thing. I lost my sister to cancer. I can say to a friend, this is how this made me feel. But I can't say to them, I know how you feel because you lost your sister. We have no idea. So develop that connection by sharing your own stories. And even with a person who is housing challenged and a substance user, you might think I have nothing in common with them. You would be surprised at the number of things on a human level that you will have in common with any individual. You can find some commonality. A lot of times I use animals. Do you have a pet? That changes the whole conversation. No, I don't have one now, but we used to have a dog when I was growing up. Really? Tell me about that dog. I love dogs. There's a connection. Find a way to connect. And participate in continuing this conversation, letting people know why the addict label doesn't work. The negative connotations that it puts on individuals that are challenged by substance use and misuse. Explain to others why the addict label doesn't work. I wear a wristband that says "Got naloxone," and I can't tell you how many times I've been shopping and people will see it and they'll ask me about it. And just the language that I use. I work for an organization that helps people that have substance issues, and we help their families. And naloxone reverses overdose, and I think that every human being should have it. You know, it's kind of like, what's your elevator speech? What's your 30-second elevator speech? What message do you want to get across to people? How do you want to do that? So pass it on and pay it forward. Correct people. Show compassion. A simple act of compassion can go so far. And you know what that compassion can be? It can be very simple. Making eye contact. You would not believe how many people avert their eyes, especially if you're doing street work, avert their eyes when they come upon those people. Make eye contact. That is the simplest way you can show compassion. Say hello. Don't walk past someone who is trying to make a living on a street corner. Even if you're not going to give them money, give them kindness, give them compassion. Look them in the eyes and say, hello, I see you. They're so used to being invisible. I could go on and on about this. Can you tell I'm a little passionate? Speak out. If you see stigmatizing behavior, whether you're in public, whether it's in the media, a billboard, a teacher at your school, speak out and share an alternative. Not in a confrontational, you know, I'm going to take you down kind of way, but with compassion. I know that when my son was first using, all of my language was bad. For my own self-help, I did a blog while he was missing and using heroin, and I go back and I read it now. I am appalled at myself with the language that I used. But you know, it just proves that we can change, and that when we know better, we do better. So let's speak out about this stigmatizing behavior when we see it. Educate not only yourself, but ask if you can hold an educational forum about stigma and language. If there aren't educational opportunities at your community college or your library, see if you can get together with some community partners and hold one. Have an educational campaign. People in substance use disorder, in the substance use disorder field, sometimes do interventions. Well, let's have our own intervention. Let's have an anti-stigma intervention and present factual information about the dangers of using language that brings people down. Start an educational campaign. I love that. Peer services. Encourage within your own community. Encourage wellness centers to have peer support specialists. Treatment facilities have peer support specialists. One of the criteria for being a peer support person, I am one, is that you have to be personally impacted and you have to be willing to share your story. That is so empowering to have someone within your treatment facility or at your clinic or in your school that has been there and is not there anymore. So empowering. Having peer services fosters non-judgmental, non-discriminatory, peer-based services. It really is invaluable. And we hear a lot about protesting these days. Protesting works, advocacy works. If you see something in your community that is stigmatizing, put together a petition. There, in one of our communities that we serve, there was a very offensive billboard that had the picture of a casket. It was for shock value. I protested it. I said, you know, I have moms that have lost their kids that drive past this billboard twice a day, and it is triggering to them. Showing people who use substances a casket is not going to get the answer that you want. And hasn't been taken down yet, by the way, but I am still protesting. So if you see something, target groups that are impacting our participants negatively, start advocacy campaigns, start a think tank, be an opinion leader, and target opinion leaders. Go and get a state rep or senator or a state's attorney or DA on your side. Make partners with a couple of influential journalists, your local mayor, your local police chief. Engage them in creating lasting change. And we can do this. It's in our hands. So let's once and for all change the stigma of disease. Always be sure when you're talking with someone about a person who uses or misuses substances that you're using non-stigmatizing language, but that you're also basing what you're sharing on science and data. And also be sure that you are within your role, that you're being consistent with the professional role that you play. Or I'm sure that there's people on this webinar that are not professionals. If you're a mom of someone, that is your professional role, and you can speak about your own experiences. Take all the steps that you can. Google, there is a group in Canada that I based a lot of this presentation on called Beyond the Label. It is a training program that they have. There's a lot of activities that you can do with your staff. There's a lot of activities that you can do with your participants. It's really, really a great program. So take all the steps that you can to reduce the potential for stigma, the potential for negative biases out there in society, the negative bias that the public has, that law enforcement has. Take the first step by learning how to avoid the terms that you use, how to change your message. Always use person-first language, whether you're talking about someone else or trying to express your own feelings. Sentences when we're working with loved ones should start with I instead of you. It just sounds differently when we're working with our loved ones and say, I am so afraid that you're going to die, than saying, don't you know you're going to die? It's the same thing. You're saying the same thing. It just sounds differently. You're being vulnerable and you're sharing your own feelings. And that's how we want to approach this. Person first language. It maintains the integrity of people as whole humans. They are not just their disease. And that goes with any disease. A person who has cancer and is going through cancer treatment, they are so much more than their disease of cancer. And we would never refer to them as a cancer. Just encourage them to see themselves as whole humans. A person with substance use disorder, and this is going to bug me now, Mike. I think I'm going to have to get rid of disorder. A person who struggles with substances has a neutral tone, right? And it distinguishes the person from the diagnoses. And that's really what we want to do. If we do more of that, maybe people will start looking at themselves as more than their diagnosis. People who are living with substance use and substance misuse, I really haven't met one who isn't ashamed and embarrassed about what they do, and they fear being judged. This is why we are losing so many people. There is no shame to having a reoccurrence of your disease. There is no shame to having a slip. But this is how people are dying, alone, in motel rooms, or at home in their bedroom, because they are so ashamed. They can't say, you know what, I just picked up and I'm going to use it. Can you keep an eye on me? This is a chronic, relapsing, remitting disease, much like cancer, but we don't judge that. We need to do what we can to reverse society's negative stereotypes about our friends who use substances. If you are in a group of friends and they refer to the crackhead down the street, have the gumption to correct them. Go out on a limb to try and change this stigmatizing way that society looks at people who use substances. And not all people who use substances have substance use disorder. People use substances for many different reasons. When we stigmatize people who use substances, there is many layers of prejudice and discrimination that creates barriers for people to seek the help that they need. People with substance use disorder, people who use substances, people who misuse alcohol, people who have mental health issues. I can speak first person. We just want to be seen as a human being. We want society to know that we are so much more than the labels that society puts on us. So much more. Every one of us has things that are negative or things that we would like to change. If you are human, You're not perfect. And just remember that. Remember that these are human beings. Just a couple of key messages about the stigma associating with concurrent disorders. We talked earlier about how things are layered. When you're working with someone who has who uses substances and is housing challenged and doesn't have a job and doesn't have transportation, very difficult to get out of that. On top of society looking right through you and not seeing you. We need to give people access to health care, affordable housing. We need to give them a second chance and give them a job. We need to give them healthy social networks. We need to help them influence their own personal dignity and self-worth. And I think that's it. You did receive an email that had both the CEU form that we need, and you will be getting certificates via email. And if you would please fill out a presentation feedback form. If you or anybody you know needs naloxone, you can reach out to us or Kenneth Young. We also provide a full range of harm reduction services, meaning safe injection, safe smoking, safe snorting materials, and safe sex materials. You can call or text our dedicated harm reduction line, and we will deliver or mail. So please share that with your clients, patients, participants, family, or yourself. Do we have questions?
Yes, we most definitely do. So, folks, if you have any questions, please use the Q&A box. An anonymous person asked, which I'm answering now, sorry. Okay, so an anonymous person asked, due to COVID-19 and safe social distancing, often we're limited to phone or video contact. What suggestions do you have to make the connection with people where you can't do it in person and read their body language?
That has been the bane of my existence since the end of March. It's very difficult. I am a person who hugs everybody. Krupa knows that. And not hugging, not being able to touch, there is so much power in being able to touch. This is exactly why we are seeing our overdose rates 50% higher than they were at this time last year. Illinois is number 2, only next to Kentucky, for EMS calls regarding overdose. Number 2. We've never been in that position. Substance use is a disease of isolation. That's what we do. We're ashamed and we isolate. And now this imposed isolation is just so much worse. Some things that I've done, I've been personally texting people just to let them know I'm thinking of them. For people, if I know where they live, I'll drop off a card and a cupcake on their porch and then send them a message. Hey, I just dropped something off. Just wanted you to know I was thinking about you. Just to try to stay connected. But just in our community circle, since COVID started, I have personally lost 5 people I know to suicide, which is more than I have in my 60 years. So that just personally is indicative to me about the the far-reaching extent of COVID-19. It's so much more than people who are dying from the virus itself. We also, in our small circle, have lost 8 people to overdose death. Just try everything you can to stay connected. And depending on what your agency's protocol is, I am going to start having a once a month, until it gets too cold, SMART meeting once or twice a month at a local park where we can be outside, we can be socially distanced, we can have masks on. Just trying to connect anyway. That probably wasn't a good answer, but I don't know what the answer is. Does anybody have any ideas about that? How do you stay connected when you can't be connected?
Yeah, I would like to share that one strategy that folks are doing because we're not able to see body language and whatnot. I mean, as Laura gave good advice, but I think one tool is using pillows or stuffed animals or something where we can touch another object or be touched by it, because it can mimic the touch of another person if touch is something that we are concerned with. I would like to, we're open if anybody wants to add to this. I do want to get to another comment that we had, is that somebody asked privately to me that they wanted clarification. Can babies be born addicted to substances if their parents are using? Laura, I think you said something about it, but I would love to hear your response. Just because.
Yeah, absolutely. That is just the wrong terminology to use. If you look at the definition of addiction, a baby cannot make the conscious decision to continue a behavior despite negative consequences. Babies can and are born with substances in their system. They can go through neonatal abstinence syndrome if they have a mother who has been using substances, but by definition, a baby cannot be born addicted.
Yes, because what I read as part of that definition is that if a person is addicted to something, they are actively seeking out that substance. But since a baby is so small, they cannot actively seek it out because they are they need another human being to help them out. But it is true that if a parent is using substances who is also carrying a child, the child can be born with the syndrome that Laura was talking about. The other question that was brought up to me is that what resources do exist for undocumented people who are seeking substance use recovery?
Cook County has clinics all throughout Cook County. I personally know that people who are undocumented can go there and receive services because I physically brought people there. So they're the access clinics. I think that's what they're called. And you don't have to reside in Cook County to utilize Cook County Health Department services. So that is one source. I also know that I live in Lake County, and we have, I don't know how much I want to say, but Lake County Health Department also sees people who are undocumented and does treat them.
Yes, I think it sounds as though in many situations, folks have to advocate or connect to organizations. I'm sure sharing stories about what an individual is going through might be helpful. I do acknowledge, though, that we have a lot of people from across the United States, so some folks may be living in locations that don't have these services. I would like to, I think Laura did a good job about advocacy and what we can do to promote change. So I definitely encourage folks to work more with the immigrant community, undocumented folks, to see what we can do to address these needs. I had another response that I saw from Grace. Grace said that, quote unquote, I work in a subacute detox unit. I'm thinking it would be a good idea to start discharging clients with Narcan before they leave the facility. But I'm worried that it might send the message that we expect to see them again.
There are several treatment facilities in our area, Gateway Foundation being one of them, NICASA, Symmetria. They all hand out naloxone to their clients. And I think it's all about the language. We want to empower you to be able to reverse an overdose, which does not indicate that they are going to be experiencing a reoccurrence. But I think it's also important to acknowledge that this is a chronic, relapsing, remitting disease, so that people, when they do slip or do have occurrences, they don't feel like a failure.
Yes, most definitely. Anna, I'm sorry, I don't know how to pronounce your name, is saying that even though Smart Recovery isn't treatment, quote unquote, I would like to share that Smart Recovery Meetings is a safe place. We have many tools available in Spanish. Elizabeth shared, NICASA also provides services regardless of immigration status.
Yep, absolutely. And we are 2 minutes past 11, so let's wrap this up, and I'll have to, but I am open to talking about this with anybody. My email is laura@liveforlolly.org, and I'd love to continue the conversation.
Yes, and before we leave, and I saw that Trinaj, I hope I'm pronouncing your name correctly, asked if they could receive the CEU link again. Yes, we will be resending the CEU link to everybody who's part of this presentation. Yes, and feel free to get in touch with Laura with any comments or questions you all have. Laura, would you like to end our presentation with any last words?
Thank you so much. Please encourage your participants to reach out. They are not alone. We are not the only organization in the area that helps people without judgment. Reach out and really do your due diligence to take a look at your materials, to take a look inside and confront your own biases. And thank you so much for being here today. I really enjoy doing these trainings.
Awesome. So with that said, everybody, have a wonderful day. Happy Recovery Month. And note that we have 4 more webinar Wednesdays during each Wednesday of this month. So please visit our website. The link was provided, cpydcoalition.org, to register for additional workshops. Thank you so much for being with us.